Morning everyone, welcome to the new episode of Dermatology Lectures. Today I am going to talk about Erythema elevatum diutinum. Erythema elevatum diutinum is a small vessel vasculitis characterized by red-violet to red-brown papules, plaques, nodules that favors the extensor surfaces. The disease can develop at any age, but it is more common in middle age and older adults, around 30 to 60 years of age. An earlier onset occurs more often in the setting of HIV infection. The male to female ratio is approximately equal and there is no racial predilection. Why do people develop erythema elevatum diutinum? Well, the exact pathogenesis of the disease is unknown, but circulating immune complexes have been detected in these patients. These immune complexes deposit on the blood vessels and result in complement activation, neutrophilic infiltration, and release of destructive enzymes. These destructive enzymes cause the deposition of fibrin in and around the small dermal blood vessels. The typical cutaneous lesions of erythema elevatum diutinum are violaceous red-brown or yellowish papules, plaques, or nodules that are symmetrically distributed. They favor acral and periarticular sites, in particularly the extensor surface of the elbows, knees, hands, ankles, and fingers. Additional sites of involvement include face, retroauricular area, trunk, axilla, buttocks, and genitalia. Initially, the lesions are erythematous, but with time they become red-brown or violaceous in color, as well as doughy or firm to palpation due to fibrosis. In general, the lesions are asymptomatic, but they can be associated with a burning sensation or pruritus. Annular plaques with raised borders and verrucous plaques on the soles have also been described. Nodular lesions, primarily palmoplantar, that progress to form bulky masses are characteristic of erythema elevatum diutinum in the setting of HIV infection. Arthralgias may develop in underlying joints, but extracutaneous involvement, with the exception of ocular disease, is extremely rare. There has been an increase in the number of the reports of associated peripheral keratitis, nodular scleritis, panuveitis, and blindness. Conditions associated with erythema elevatum diutinum can be divided into infections, hematological disorders, and autoimmune diseases. Associated infections include beta hemolytic streptococci, hepatitis B virus infections, HIV, tuberculosis, and syphilis. Lesions identical to erythema elevatum diutinum, both clinically and histologically, have been reported by the intradermal injection of streptococcal antigen into the non-lesional skin of the patients with erythema elevatum diutinum. In patients with HIV, erythema elevatum diutinum may be due to either HIV-related antigen-antibody complexes directly damaging small blood vessels, or HIV-induced immunosuppression, allowing other infectious agents to serve as the antigenic stimulus. Autoimmune or inflammatory conditions associated with erythema elevatum diutinum include granulomatosis with polyangiitis, inflammatory bowel disease, celiac disease, relapsing polychondritis, SLE, and rheumatoid arthritis. In addition to plasma cell dyscrasias, especially IgA monoclonal gammopathy, associated hematological disorders include myelodysplasia, myeloproliferative disorders, and hairy cell leukemia. In patients presenting with erythema elevatum diutinum, evaluation for an associated infection, monoclonal gammopathy, or autoimmune diseases should be considered based upon the clinical context. Like I said in the pathogenesis, that there is immune complex deposition leading to vasculitis. So in early lesions of erythema elevatum diutinum, demonstrate the changes of leukocytoclastic vasculitis with a neutrophilic infiltrate within the upper and mid dermis mixed with some eosinophils. Involvement of papillary and perifollicular adventitial dermis without a Grant zone is observed in more mature lesions. Mature lesions are also characterized by the presence of granulation tissue and perivascular concentric or storiform fibrosis plus mixed inflammation that is composed predominantly of neutrophils. In late stage, capillary walls may have fibrinoid necrosis or fibrosis. Vertically oriented capillaries are also seen, and it may be difficult to discern the features of vasculitis. Cholesterol deposits in histiocytes and in the extracellular tissue. The deposition in the extracellular tissue is known as extracellular cholestasis, may be present in the older lesions. So the histopathology of erythema elevatum diutinum is quite simple. Initially, there is leukocytoclastic vasculitis with inflammatory infiltrate, which is neutrophilic predominant, which leads to fibrosis or fibrinoid necrosis in the later stages. Direct immunofluorescence studies are usually not necessary for the evaluation of erythema elevatum diutinum, but if performed, perivascular deposits of fibrin, complement, immunoglobulins may be seen. The clinical differential diagnosis depends upon the stage of the lesions. For earlier lesions, one needs to consider neutrophilic dermatosis, for example, neutrophilic dermatosis of the dorsal hand, Sweet syndrome, rheumatoid neutrophilic dermatosis, and palisaded neutrophilic and granulomatous dermatosis. Sweet syndrome is an acute neutrophilic dermatosis characterized by multiple tender erythematous plaques or pustules on the face, neck, upper trunk, and extremities. Associated fever, leukocytosis, arthralgias, myalgias, headache, and general malaise are common. On histopathology, there is diffuse neutrophilic infiltrate in the upper dermis. Unlike erythema elevatum diutinum, leukocytoclastic vasculitis is usually absent in Sweet's disease. Rheumatoid neutrophilic dermatosis classically presents as asymptomatic papillonodules or plaques distributed on the extensive surfaces of the extremities, particularly the hands and the forearms, as well as neck and trunk. Rheumatoid neutrophilic dermatosis usually occurs in association with rheumatoid arthritis but can also develop in the patients with seronegative arthritis. Histological findings include dense dermal infiltrate without vasculitis. Palisaded neutrophilic granulomatous dermatosis is a rare neutrophilic dermatosis with varied clinical presentation. The most common clinical presentation is the erythematous papules symmetrically distributed on the extensive surface of the upper extremities, especially the fingers and elbows. Palisaded neutrophilic granulomatous disorders usually presents in the patients with underlying systemic conditions such as rheumatoid arthritis and autoimmune diseases, lymphoproliferative disorders, or infections. Late-stage lesions primarily may be confused with the tuberous synthomas, granuloma annular, rheumatoid nodules, fibroid nodules of Borrelia, multicentric reticulohistiocytosis. Other granulomatous disorders, example sarcoidosis, leprosy, necrobiotic xanthoma, are sometimes under differential diagnosis. For an isolated lesion, dermatofibroma or dermatofibrosarcoma protuberans must be included. Occasionally, lesions with a prominent vascular component, especially in an HIV patient, may be mistaken for Kaposi sarcoma or bacillary angiomatosis. Tuberous synthomas present as pink-yellow papules or nodules on the extensive surfaces, especially the elbows and knees. Tuberous synthomas occur in association with the disorders of lipid or cholesterol metabolism. A biopsy reveals foamy cells and cholesterol clefts. Rheumatoid nodules are common in the patients with rheumatoid arthritis. Affected patients develop firm semi-mobile nodules that are several millimeters to few centimeters in diameter. Rheumatoid nodules are usually found in the periarticular location over the extensive surfaces and in an area subject to pressure or trauma. The nodules are often asymptomatic but may be tender or painful, particularly if there is associated trauma or ulceration. Histological findings include a central zone of brightly eosinophilic fibrin surrounded by a palisaded layer of histiocytes and granulation tissue. Acute or early lesions may show a leukocytoclastic vasculitis or interstitial neutrophilic infiltrate. Multicentric reticulohistiocytosis is a disease characterized by cutaneous and mucous membrane reticulohistiocytomas and square arthropathies. The cutaneous manifestations are skin-colored pink, red, brown, or yellowish papules or nodules that range from a few millimeters to 2 centimeters in diameter. Favored sites include head, hands, finger, ears, and articular regions of limb. Small papules aligned along the periungual region result in the characteristic coral bead appearance. Numerous multinucleated giant cells with eosinophilic granular cytoplasm is the key histological finding. Histopathologically, the earliest lesions may share features with neutrophilic dermatosis, but foci of leukocytoclastic vasculitis help to distinguish erythema elevatum diutinum. Granuloma faciale may also be considered, but a predominance of the eosinophils and plasma cells and the presence of a gran zone in granuloma faciale is a distinguishing features, as well as localization of the lesions to the face. In addition, the presence of the granuloma may be more likely in erythema elevatum diutinum compared to granuloma faciale. The differential diagnosis of the later lesions include tuberous xanthoma, fibrotic disorders or tumors such as DFSP, and occasionally fibroid nodules of Borrelia, Kaposi sarcoma, and bacillary angiomatosis. Once the diagnosis of erythema elevatum diutinum is made, the possibility of an associated disease should be considered. Appropriate initial tests to evaluate for the underlying diseases include complete blood count, comprehensive metabolic profile, HIV test, immunofixation with electrophoresis, anti-streptolysin O titers, hepatitis B/C serology, anti-nuclear antibodies, anti-neutrophilic cytoplasmic antibodies, antiphospholipid antibodies, chest radiograph, and urine analysis. Specific testing for other infections or autoimmune diseases should be based upon the presence of suggestive signs and symptoms or patient's history. Performance of a complete review of systemic and physical examination is optimal. Because ocular abnormalities may occur in the patients with erythema elevatum diutinum, referral for ophthalmologic evaluation is appropriate for the patients with ocular symptoms. Depsoned induces dramatic improvement, but relapses frequently occur upon discontinuation. Depsoned is often ineffective for the fibrotic lesions of erythema elevatum diutinum. Therefore, Depsoned may be most beneficial for early lesions. Depsoned therapy for erythema elevatum diutinum has been given in the doses ranging from 50 to 300 mg per day. A lower dose is typically administered, 25 to 50 mg, at the start of the treatment. The dose is then titrated upwards dependent on the patient's tolerance and response to therapy. The usual adult dose for erythema elevatum diutinum is 100 mg per day. Benefit of Depsoned for erythema elevatum diutinum may be dose dependent. Reduction in the size of the erythema elevatum diutinum lesions may be evident within the first few months of the treatment. Depsoned therapy is associated with a risk for a variety of the adverse effects, including hemolysis, agranulocytosis, methemoglobinemia, Depsoned hypersensitivity syndrome, and peripheral neuropathy. Although hemolysis occurs to some degree in all patients, individuals with G6PD deficiency are at increased risk for severe hemolytic anemia. Therefore, screening for G6PD deficiency should be performed prior to initiating Depsoned therapy. Monitoring for hematological or liver abnormalities is also indicated during the Depsoned therapy. Other therapies include NSAIDs, niacinamide, tetracycline, chloroquine, colchicine, and plasmapheresis. High-potency topical and intralesional corticosteroid may be helpful for mild cases. 5% topical Depsoned gel has been described as effective. Erythema elevatum diutinum usually has a prolonged course characterized by fluctuating periods of exacerbations and stability. The disease may resolve spontaneously after 5 to 10 years, however, persistent up to 40 years has occurred. Erythema elevatum diutinum does not progress to systemic vasculitis. Recurrence is common after the cessation of Depsoned therapy. So for a quick review, erythema elevatum diutinum is a chronic form of cutaneous small vessel vasculitis consisting of violaceous red-brown or yellowish papule plaques or nodules that favor the extensor surfaces. Histologically, leukocytoclastic vasculitis is a key confirmatory diagnostic feature. Erythema elevatum diutinum may occur in association with infections, hematological abnormalities, autoimmune diseases, or other conditions. Oral Depsoned is the primary mode of the treatment. If you have to remember one word from this lecture, it would be erythema elevatum diutinum is equal to fibrosing leukocytoclastic vasculitis. Thank you so much for watching my video. Don't forget to subscribe to my channel and hit the bell icon to get notification. You can also follow me on Instagram at Dr. Namra Aziz. If you like my video, please don't forget to share it with your friends and family. Thank you so much.